So, good morning, good evening, or good night, everybody, whatever the time zone is you are attending this webinar. And it's really a pleasure for me to welcome you on this webinar series of the International Society of Critical Care Nephrology. Today we will have the first of a series of three topics, and this series will deal with the overall content of dialytrauma, dynamic dosing, and sustainability of RT. So maybe it's a bit off the track usually experience when talking about extracorporeal therapies and renal therapies, where we always talk about doing more. And here we talking about the other aspects which are very important. And it's a really great pleasure to introduce to you our speaker. She is a real expert in the field. It's Dr. Emily C. She's a consultant intensivist and nephrologist at the Royal Melbourne Hospital and a senior research fellow at the University of Melbourne, Australia, and an adjunct senior research fellow at Monash University. She's a JACO Research Establishment Fellow and an NHMRC Emerging Leader. She holds a Master of Medical Statistics degree from the University of Oxford and a PhD of Clinical Medicine from the University of Melbourne. Her clinical research interests center about acute kidney injury, continuous renal replacement therapy, and sepsis. And before I forgot it, my name is Michael Ioannidis. I'm currently president of the ISCCN. I'm an intensivist and nephrologist. Now back to Emily. Emily, welcome. I'll hand over you the screen, and we are really looking forward to your talk.
Thank you. I'm just going to share my slides. I'd like to start by thanking Nordia and the ISCCN for the opportunity to speak to you today in this webinar that's going to be, as Michael said, the first of a series looking at the dose of dialysis and whether the dose of dialysis may influence patient outcome. And I hope we'll understand a little bit more about that after the next 30 to 40 minutes. So dose and dialytrauma, is more CRRT always better? So renal replacement therapy is one of the most common organ supports we deliver in the intensive care unit, being received by as many as 5 to 10% of patients. It may be initiated for a number of different indications, including removal of solutes, fluid and toxins, and often these are life-threatening disturbances that renal replacement therapy is being initiated for. We're increasingly recognising that how we prescribe and deliver renal replacement therapy is an important contributor to patient outcome, and a lot of this seems to centre around the biocompatibility of the system, which is well understood to be crucial. So when we look at the reasons that CRRT or other types of renal replacement therapy may not be biocompatible, there are a number of different important considerations. So firstly, renal replacement therapy involves a blood circuit interface. Secondly, we need to insert vascular access and usually initiate anticoagulation. Thirdly, we alter drug pharmacokinetics, and so dosing of drugs, especially antibiotics, is greatly important. We also alter plasma composition and intravascular volume, and rapid changes in these variables may translate into adverse clinical outcomes. Dialytrauma is a term that's been used now for many years to encompass all harmful events relating to renal replacement therapy. And dialytrauma includes events that involve the circuit mechanics and also the interface, the removal or potentially addition of fluid and solutes, and finally the unwanted removal of substances like drugs and antibiotics. We've really known about dialytrauma though for a lot longer than the last few years, and the recognition that the procedure of renal replacement therapy itself may harm patients has been described for some time, including in this report based on casualties from the Vietnam War. These patients included in this case series had renal ischemia, so hypoperfusion from trauma or surgery, and were receiving hemodialysis either every day or every second day, often complicated by hypotension. In these patients, a number of biopsies were performed, and in patients who eventually died, necropsy was performed, revealing areas of fresh tubular necrosis that were estimated to be 48 to 72 hours old. And unfortunately, that was far distant to when the original injury or surgery had occurred, suggesting that such areas of necrosis were unlikely to be the result of the initial ischemic insult that had happened 3 to 4 weeks earlier. When they reviewed the files, there were no obvious hemodynamic catastrophes in the days prior to biopsy that would account for fresh ischemia. And the only hemodynamic aberration was the provision of renal replacement therapy with transient blood pressure reductions down to 70 or 90. Since then, we've come a long way in our understanding of dialytrauma, especially since publication of the START-AKI trial, which highlighted important findings regarding renal replacement therapy dependence in the patients who were included. This particular slide details one of the important secondary outcomes of RRT dependence, which was found to be significantly higher at 10.4% in patients in the accelerated strategy compared to 6% in patients in the standard strategy. Importantly, almost all patients, 96.8% in the accelerated strategy, received renal replacement therapy, whereas less than 2/3 of those in the standard strategy required RRT. So we can ask, is the RRT dependence that's been recorded the result of receiving RRT or receiving early RRT? Well, luckily, our colleagues have already performed a post-hoc secondary analysis of, to answer this question, of the START-AKI cohort. So this is the secondary analysis of START-AKI, just looking at patients who actually received renal replacement therapy. And as you can see, there was no significant increase in the risk of kidney replacement therapy dependence at 90 days in the accelerated versus standard group, suggesting that the harmful effects of long-term CRRT dependence identified in the primary study may largely be due to initiation itself rather than the timing. So if we further explore the hypothesis that renal replacement therapy may have adverse outcomes for patients, there's a number of ways that we can categorize the types of injuries that may occur. And these can broadly be classified according to organ system as cardiovascular, gastrointestinal, renal, neurological, metabolic, or other disturbances. And many of these relate to hemodynamic changes or fluid changes, while others relate to changes in plasma composition. And so I'm going to explore these separately. Starting first with the circulatory effects of renal replacement therapy, it's important to remember that during renal replacement therapy, plasma water is removed from the intravascular compartment by the renal replacement therapy machine, and that removed fluid is replaced by fluid from the interstitial compartment. Now, the intensity or the rate of fluid removal by the machine differs between continuous and intermittent therapies, and that may help to explain some of the differences that we see in outcomes between these patients. The vascular refilling rate is going to be really important in critically ill patients because there's many reasons why our vascular refilling rate may vary widely when we look at some of its determinants. Fluid status is an important determinant, as well as plasma oncotic pressure and transcapillary hydrostatic pressure, and finally endothelial function. So you can imagine that in a patient with sepsis who's newly admitted to the intensive care unit, their rate of vascular refilling from the interstitial compartment into the intravascular compartment is going to vary markedly compared to a patient who has had a drug overdose or has a reason for admission that doesn't impact those variables. So why is it that the vascular refilling rate matters? Well, when the net ultrafiltration rate by the machine is significantly higher than the vascular refilling rate, we enter a state of volume contraction. And this manifests with decreased preload, stroke volume, and cardiac output. And at the bedside, we see hypotension and organ perfusion. So what impacts could this intravascular volume contraction have on organ perfusion in the critical care setting? Well, it may impact a number of organs, and I'm going to now go through some of the data we have supporting organ hypoperfusion relating to renal replacement therapy, starting with the kidney. So in this study, 29 patients undergoing, and so a lot of these data actually come from the intermittent hemodialysis literature, and within the intermittent hemodialysis literature, some refer to chronic kidney disease and some are in patients with acute kidney injury. So we're having to extrapolate data from other settings. So in this study, we've got 29 patients undergoing intermittent dialysis while in the CT scanner looking at the impact on renal perfusion. Imaging was performed before, during, and after intermittent renal replacement therapy, and the investigators found a significant reduction in renal perfusion during RRT with a mean reduction of 18.4%. When they looked at the perfusion after renal replacement therapy, it had recovered to only 95% of the baseline. So there was a persistent reduction in renal perfusion even after renal replacement therapy had finished. Similar changes can be seen in the myocardium, where in the same study, echoes were performed in patients undergoing intermittent hemodialysis, looking for regional wall motion abnormalities or myocardial stunning. So the investigators found that myocardial stunning occurred in 83% of patients, and that the number of stunned segments correlated with the change in renal perfusion that they'd seen during the CT scan, suggesting it's a simultaneous multi-organ, multivascular bed effect. Importantly, patients who didn't have myocardial stunning were protected from decreased renal perfusion. And perhaps most concerningly, such changes occurred in the absence of significant hypotension. So such phenomena may be happening without us knowing at the bedside because we're not continually echoing or checking the renal perfusion of such patients. And we do rely very much on gross markers of hemodynamic status, such as blood pressure. They correlated the number of stunned segments as well as the change in renal perfusion with the intensity of fluid removal as a potential mechanism. And they did identify that the greatest changes in perfusion of both the kidneys and the myocardium were associated with greater intensity of fluid removal, suggesting that high renal replacement therapy dose in terms of fluid management may be harmful to patients. This study, so the previous study was in patients with chronic kidney disease. Here we've got a study of patients with acute kidney injury, including one of our chairs, Louis. So this study was in 11 patients requiring renal replacement therapy for acute kidney injury, and they underwent echo before, during, and after their renal replacement therapy treatment. The investigators found that all patients developed at least 2 new regional wall motion abnormalities during their intermittent hemodialysis session, and the median number of affected segments was 5, so very high. The changes persisted after dialysis, and they also found a global reduction in LV contractility. High sensitivity troponin levels were measured before and at 6 hours after dialysis, and they were significantly higher at the 6-hour mark compared to pre-dialysis. Other studies had looked at risk of arrhythmia. So this is a study of 32 patients undergoing intermittent hemodialysis in the chronic setting, and 8 of 32 patients developed ischemic changes, and none had a history of coronary artery disease. There was significant ST depression lasting between 40 and 90 minutes, ventricular tachycardias, ventricular premature beats, and similar findings have been replicated in 10 subsequent studies. So we've got regional wall motion abnormalities, increased troponin, LV, decreased LV function, and ST depression and arrhythmias. The brain is not spared. In this study of 15 patients with acute kidney injury undergoing intermittent hemodialysis, transcranial Doppler was performed before and during renal replacement therapy and at the end, and the investigators found a significant decrease in the mean flow velocity across the dialysis treatment, and that difference persisted even after adjustment for the baseline and the intensity of ultrafiltration or fluid removal. There wasn't a clear contribution relating to changes in plasma osmolarity, rheology, or vasoreactivity, and the authors hypothesized that impaired organ autoregulation, in this case cerebral autoregulation, may have accounted for some of the change. Finally, we've got a study in 15 patients who underwent CT liver perfusion before, during, and after hemodialysis. And in these patients, hemodialysis was found to redistribute liver perfusion with increased portal perfusion and heterogeneity. Hepatic function was attenuated, which manifests as a reduced ICG clearance, and circulating endotoxin levels were higher, especially in those patients in whom heterogeneous liver perfusion had been identified. So now we've got evidence that changes in organ perfusion and organ function can be demonstrated during dialysis in myocardial, renal, hepatic, and cerebral vascular beds. So there's changes beyond vascular and hemodynamic changes that classify as dialytrauma, and these are ones that we're increasingly recognizing, especially due to the vulnerability of critically ill patients. So many of the other types of dialytrauma, unlike the fluid component of the renal replacement therapy prescription, these relate often to the solute clearance component of the dialysis prescription. So now looking at dose in terms of effluent dose or solute clearance. So there's long been interest in the impact of the dose of renal replacement therapy on patient outcomes in those with acute kidney injury. And this is one of the first key studies published in 2000 in The Lancet by Claudia Ronco. So this was a study of 425 patients with acute kidney injury, then referred to as acute renal failure in the ICU, who were randomly allocated to effluent doses of 20, 35 or 45 mils per kilo per hour, with a primary endpoint of survival at 15 days. In this study, survival in group 1, which was the low dose, was significantly lower than in group 2 and 3, which had very similar survival. So you can see from the Cox regression models that low dialysis, so less than 20 mils per kilo per hour, had a 49% lower survival compared to moderate, and a 51% lower survival compared to high. And so based on these data, there was great interest in confirming these changes. And in the meantime, the authors recommended that ultrafiltration should be prescribed according to patient body weight and at least 35 mils per kilo per hour. So after that study, we had 2 much larger multi-centered trials, so the ATN trial and the renal trial. ATN was done in the United States and was published in 2008, and renal was done in Australia and New Zealand, published in 2009. Both were large studies with over 1,000 patients, multi-centre, individually randomised trials. Importantly, there was a slight difference in the intervention or the high dose and low dose groups. So in ATN, the high dose was 35 versus 20, and in renal, it was 40 versus 25. There were also slight differences in the patient population and the modality of renal replacement therapy. So in ATN, there was a higher proportion of patients with sepsis compared to in renal. And also in ATN, they included multiple modalities of renal replacement therapy, including SLED and intermittent hemodialysis, compared to just CRRT in the renal trial. Looking first at the ATN results, we can see that there with intensive renal replacement therapy versus less intensive. And so this was in contrast to the earlier findings published by Ronco and team. And concerningly, there were a number of adverse events identified in the intensive strategy, including hypotension, hypokalemia, and hypophosphatemia, which really led to guidelines to err away from high-dose renal replacement therapy, for which there didn't appear to be a survival benefit. The following year, we had publication of the renal trial, which reported very similar findings, which was reassuring in that there was no difference in survival, this time at 90 days rather than 60 days in ATN, between patients in the higher and lower intensity renal replacement therapy groups. Again, there was a much higher incidence of hypophosphatemia in patients allocated to the high intensity group. And there was also a borderline significant increase in the number of patients with disequilibrium. So again, we have evidence, or we have two large trials that did not show superior survival with high dose, but did show an accumulation of adverse events and complications. So subsequent to publication of these trials, we have an individual patient data meta-analysis that compared high and standard intensity renal replacement therapy, comparing a number of the trials in this area, including the three large trials that we've just seen. They looked at a primary outcome of all-cause mortality, but they also looked at a secondary outcome of renal recovery, based on the emerging data that more intense renal replacement therapy may delay renal recovery. So in this IPD, there were almost IPM, individual patient meta-analysis, there were almost 2,000 patients who had follow-up to 90 days, which is when they were looking at the renal replacement therapy outcome. And you can see in the Kaplan-Meier curve on the right that the probability of being renal replacement therapy dependent, so still requiring renal replacement therapy, was greater in patients in the high intensity group compared to the standard intensity group. And so the authors concluded that higher intensity renal replacement therapy in terms of the dose of solute clearance may delay recovery to RRT independence. They did also report mortality, and there was no difference in mortality when the patients from the large trials were pooled, either at 28, 60 or 90 days. So then we're wondering, well, these trials have compared high dose CRRT to standard dose, but what if standard dose is still too high? So now we've seen an increasing interest in the exploration of even lower dose renal replacement therapy. And there's currently a number of trials that are ongoing to compare standard dose and lower dose. We've got the Wisdom trial, CATS-RI trial, and the LIMIT trial, and we're hoping to see the results of these studies over the next couple of years. So in preparation for these trials, there was a systematic review and meta-analysis performed by many of the lead investigators of the trials, looking at the primary exposure of low-dose CRRT, so less than 20 mils per kilo per hour, compared to standard dose, which in many guidelines is approximately 25 to 30 mils per kilo per hour as prescribed effluent dose, acknowledging that the actual delivery of the renal replacement therapy is often slightly less due to treatment interruptions. In this systematic review and meta-analysis, they've looked at the primary outcome of ICU mortality. So a total of 14 studies were eligible for inclusion, and the authors found some important or interesting effects in terms of survival. So when they looked at studies comparing intensity of solute clearance of less than 20 mils per kilo per hour to greater than 20 mils per kilo per hour, there was a 23% lower incidence or lower risk of ICU mortality and a 14% lower risk of 90-day mortality. But when they compared doses of less than 13 to greater than 13 mils per kilo per hour, there was a higher incidence of 90-day mortality. So there may be a sweet spot for patients somewhere between 13 and 20. And certainly we're looking forward to seeing the publication of these studies to help guide whether how we're currently prescribing renal replacement therapy is still excessively high. In terms of renal recovery, there was no difference with the standard dose versus with the low dose versus the standard dose. They did, in this systematic review, also look at some of the complications of higher dose or standard dose renal replacement therapy. And there were insufficient numbers of studies or excessive heterogeneity to perform any pooled analyses, but they did report that there was no difference with potassium between standard and low dose intensity groups, nor was there a difference in phosphate. So in general, these studies have been relatively small and insufficiently homogeneous to perform pooled analyses. So more recently, so this is from, this was presented at American Society of Nephrology last year. So this is a study looking at real-world data of CRRT dose prescription. This is based on the CRRT Net registry, which is a multi-center observational study of adults receiving CRRT. And so as part of the CRRT Net registry, they've performed a study looking at adults who underwent CRRT for at least 1 day and who didn't have end-stage kidney disease. And what they found, so in terms of the total size, there were 931 patients who were eligible. And in the top left panel, they've categorized patients according to the average dose and the starting dose. And concerningly, you'll see that the most common intensity of CRRT dose in the registry is greater than 30 mils per kilo per hour. So more than 50% of patients received this intensity, with only about 30% receiving, only about 30% receiving current guideline therapy in terms of the dose. The median dose in the cohort was 32.1 mils per kilo per hour, and they identified several variables that were associated with higher dose, including lower BMI, uremia and hyperkalemia, vasoactive drugs, and the presence of fluid overload. And concerningly, they identified an independent association between the dose of solute clearance and in-hospital mortality, with each mil per kilo per hour being associated with a 2% increase in the risk of death. So we have a really growing body of evidence that aggressive renal replacement therapy or excessive renal replacement therapy, either in terms of fluid removal or solute clearance, may increase adverse outcomes for patients. So organ hypoperfusion, electrolyte disturbances. And so what are the potential interventions that we can look at to try and mitigate some of the dialytrauma in our patients? Well, this slide really just summarizes some of the interventions that are currently under investigation and planned for investigation. And so if we look at some of the ones that are currently ongoing, there's several trials that are looking at avoiding excessive fluid removal. So Ragi Murugan and colleagues have performed the Relieve AKI trial, which was a pilot trial looking at limiting the intensity of fluid removal. In Australia, we're performing the Neptune trial, which again is avoiding excessive fluid removal and looking at renal recovery. We've got studies looking at advanced hemodynamic monitoring and if we can predict or identify patients who are at risk of organ perfusion. And one of these techniques is in using blood volume monitoring to identify intravascular volume contraction. As I mentioned, there's a number of trials looking at decreasing the effluent dose, so LIMIT, CATS-RI and Wisdom, and we look forward to the results of those trials shortly. But there's a number of other interventions that also warrant exploration, and many of these are derived from the intermittent hemodialysis outpatient literature, but warrant exploration in our critical care setting. So bringing this all together, dialytrauma is the term that encompasses all harmful events relating to renal replacement therapy, and the origin of many of these events is exposure of blood to the extracorporeal circuit, removal or potentially addition of fluid and solutes, and unwanted removal of drugs. The impact of dialytrauma is multi-organ and multifactorial, and it's possible that its consequences are preventable. And so testing interventions that may mitigate some of the injury that we inflict on patients through the prescription of renal replacement therapy certainly warrants further exploration. Current data are largely extrapolated from the chronic and intermittent renal replacement setting in terms of the impact of fluid management, but reassuringly, we have several trials that are actively investigating novel interventions relating to the dose of fluid removal and solute clearance in order to minimise dialytrauma and improve outcomes for our patients. Thank you.
Yeah, thank you, Emily. This was a fantastic talk and really eye-opening. I learned many unknown aspects for me. Thanks, it was really brilliant. While we are waiting here for question and answers, and I invite the audience to put the questions in the chat, I think we start discussing a bit some of the aspects you were showing in your wonderful talk. You showed quite a lot of studies showing an impact of intermittent dialysis on the stunning and the kidney perfusion. And I was wondering, the stunning per se, was this clearly associated to hypotension, or was that independent and you had hypotension in the conjunction with the stunning, myocardial stunning? Is there any evidence showing us the solution for the hen and egg problem here?
So concerningly, the studies that did report blood pressure in association with myocardial stunning found that there was no correlation between hypotension and the myocardial stunning. So it's not so much a macrovascular problem purely that we're seeing. And concerningly, in many intensive care units and certainly on the ward, the blood pressure is the main marker of hemodynamics that we have to guide especially fluid management in patients. So obviously in the intensive care, we've got other ways of monitoring hemodynamics for many patients that are more advanced, but it's greatly concerning that blood pressure was often stable in patients who are having significant hyperperfusion of their or who are having myocardial stunning and regional wall motion abnormalities that were presumed to relate to altered perfusion of the myocardium. And similar findings have been reported in the outpatient setting when we look at the intermittent hemodialysis literature in patients undergoing IHD for chronic kidney disease, where blood pressure has been found to be a poor correlate of organ hypoperfusion, meaning that we need, if we're going to try and identify patients who are at risk of hypoperfusion before it happens, blood pressure is not necessarily going to be the key marker. We also know that in critically ill patients that blood pressure doesn't always correlate with organ perfusion, and that in many cases it's a poor marker. Patients are very complex, and hypotension is often multifactorial and not purely relating to fluid mechanics. And so I think at the moment we don't yet have good tools to identify patients who are at risk of organ hypoperfusion during renal replacement therapy. And that is the basis then of the trials that are looking to see whether minimisation of excessive fluid removal, so limiting net ultrafiltration rate in all patients, can globally be associated with improved kidney and patient outcomes.
Now, beside fluid removal and this aspect, is it conceivable that we have some microinflammatory processes going on here, which are not dependent on fluid removal, or only partly associated with dose? Is there an explanation you can give for this?
Absolutely. So this is one of the main differences between critically ill patients and the outpatients when we're looking at extrapolating the data. So in outpatients, it's very predictable. The refilling of outpatients, well, dialysis patients have a chronic low-level inflammation, but their rate of vascular refilling is much more predictable, and it's been reported to be about 2 to 3 mils per kilo per hour quite reproducibly. Whereas in critically ill patients, many of whom have sepsis and other very pro-inflammatory conditions that impact the integrity of their endothelium, the impact of inflammation on fluid movement between compartments is much more important. And so we've all seen patients in the intensive care unit who are having no fluid removal via the CRRT machine, but who have progressive intravascular volume contraction despite that, as their fluid moves from the intravascular to the interstitial space very readily. And so we then have a situation where we've got a lot of heterogeneity between patients, but also within patients along their clinical trajectory. So a patient who's in the resuscitation phase of septic shock, who's initiating renal replacement therapy, has a very different level of inflammation and intravascular to interstitial fluid movement compared to a patient in whom stabilization has occurred and in whom it's presumed their endothelium is more predictably intact. So it's then very hard for us to design trials and interventions that account for both groups. And this may be one of the explanations why the existing data haven't been clear in terms of the impact of fluid removal. And this relates back to, I think, what we're finding more and more in critical care nephrology. The timing of the intervention is critically important when we design trials, because it's acute kidney injury is a very dynamic and heterogeneous process. And if we're not applying the interventions at the correct times, we may actually miss patients who may benefit, and importantly, also not identify patients in whom harm is occurring. And I think this area will be really interesting when we look at some of the solute dose trials, especially in our next webinar, which is going to be looking at dynamic dosing, because I'm not sure how it is in all of your units, but in my unit, patients tend to have, they're either on CRRT or they're off. We don't actually vary the dose during the treatment. And so it may be that patients, as they're experiencing renal recovery, even though they're within the guidelines of approximately 25 mils per kilo per hour, as their endogenous renal recovery occurs, they're actually having excessive clearance of all the constituents of their plasma volume. So I think the dynamic dosing that we hear about next week will really tie in really nicely with what we've discussed today.
Yeah, that's an important point when you address that dosing. What I always wonder is when we talking about dosing, we are actually not using any target parameter at which we are orientate our dosing? I mean, are there any data about target parameters which we should use or should consider for future trials?
So I think the difficulty is finding this as such a target or a marker that can be widely applied in all intensive care settings. So it's similar to what we've seen with biomarkers, where even though there are some biomarkers that may be useful in terms of prediction or prognostication, limited availability means that that they can't be applied to benefit most patients. And it's the same when we're looking at dose. So effluent dose has been around for a very long time as a crude marker of the dose of renal replacement therapy. And if we look at, say, the intermittent hemodialysis chronic literature, they're targeting markers like KT-on-V, urea reduction ratio, and those thresholds that they use are linked to quality. In some countries, they're linked with funding, and they have also been linked with patient outcomes. Yet we don't have such markers that are yet validated in the critical care setting. And markers such as urea and creatinine are very fraught in our patients, especially relating to changes in muscle mass that occur. And so we tend just to use effluent dose as the marker in our unit, but hopefully we'll be able to identify better markers moving forward to help guide the prescription, because effluent dose is very crude, and we're not even yet sure exactly how it correlates to patient-centered outcomes like survival and renal recovery.
I'm still waiting for any Q&As, but the chat, nothing has appeared yet. Maybe let's go to the last question on my behalf. I mean, you quite nicely showed first in the START AKI analysis, there was demonstrated is the association with early start and longer dependency on RRT. But then when you're doing the correct sub-analysis, it seems that just starting RRT has always the same risk of being dependent. Huh? So whenever you start RRT, you have about 10% chance to be dependent on RRT at 90 days. Is that a correct interpretation, or what? How would you see the data?
Yeah, so that's how I would interpret it, that if we look at the patients who were eligible for START AKI, so that's patients who have at least stage 2 AKI, and the full list of inclusion and exclusion characteristics are in the paper, but if those patients start within 6 to 12 hours of meeting eligibility criteria, that a number of them will actually require long-term renal replacement therapy, at least at 90 days, which is when we cross over from definitions like acute kidney injury and acute kidney disease into chronic kidney disease. And the reason that I believe it to be true is that actually very similar data have been demonstrated in patients newly initiating renal replacement therapy in the chronic setting, where we have patients who start with, measuring residual kidney function is a little bit harder in the chronic setting, but one of the, again, crude markers is residual urine output per day, and there have been a lot of studies that have shown reduction in residual urine output and creatinine clearance after initiating dialysis. So the trajectory of decrease changes quite markedly following initiation. And so I think the data that we see in the acute setting are biologically plausible and also supported by those from chronic. And so it reinforces to us that that there's unlikely to be a benefit overall to patients for initiating renal replacement therapy without one of the recognised indications. Obviously, we've also got AKICI 2 that then says that if we wait really, really, really long, we may end up increasing mortality as well. And so I think very much that supports the current approach that we're taking, where we don't start renal replacement therapy purely for a diagnosis of acute kidney injury, but we do start it when there's a life-threatening disturbance of acid base, biochemistry, or fluid. And I think one area, so this is all obviously coming out of the adult literature, but the pediatric literature tends to be quite different, because in critically ill children, it tends to be that they're much more prone to fluid overload, and so renal replacement therapy may be initiated earlier as a prevention tool. And so it'll be interesting to see pediatric data that comes out regarding the timing of initiation in that group, which is slightly different to the adult cohort.
Yeah. So I think, yeah, I'm still waiting, but there are no questions from the chat. So
we've got one question in the chat.
Okay.
In the Q&A section. I can read it if you wish.
Yeah, please go ahead. I don't see it. I'm sorry. Yeah.
Okay, so question for Emily. Since you are both a researcher and a practitioner, I was wondering how you either have or are planning to incorporate this evidence related to dosing in your own practice.
Yeah, I think that's a really good question. So at the moment, we're currently doing so if we think about the two elements separately, so thinking firstly about the fluid management component. So we're conducting the Neptune trial currently in Australia, which is comparing a net ultrafiltration rate of less than 1.75 mils per kilo per hour to usual care. So in terms of how I'm incorporating this data currently, I'm trying to discourage my colleagues being aware of it, because I want them to be very true to their bad habits of aggressively removing fluid for patients, so that we can see a separation between groups and answer the question. But I think that, so it was quite interesting. As part of Neptune, we did an implementation science analysis, which is just being finalised in terms of the analysis. And so this involved a lot of interviews of both medical and nursing staff about their perceptions of fluid removal. And it's interesting because there was a real dichotomy between people thinking that they would never prescribe a fluid removal greater than 1.75 mils per kilo per hour, and thinking that there won't be any separation in the trial because obviously everyone's fluid removal is below that level, compared to other colleagues thinking it was safe for a patient to be 3 or 4 litres negative in a day. And so I think in the absence of evidence, there's a lot of heterogeneity on the floor between how clinicians are practicing. And so I think at least having some evidence to create some sort of guidance to try and minimise some of the variations in care will be important. So I hope that once both Relieve and Neptune are published, that there may be a larger trial to confirm definitively. Relieve was a relatively small pilot at 97 patients. Neptune is cluster crossover of about 700 patients, but we anticipate that there may be further work required to identify especially subgroups of patients. But I think overall, avoiding excessive fluid removal greater than 1.75 mils per kilo per hour would be what I would be advocating for in my unit. In terms of solute clearance, so this is more complicated, and we're actually currently going through our own data, and I would encourage people to look at their data within their unit, because I was quite shocked to see how high some of our effluent doses were. So we try in theory to have a 25 to 30 mil per kilo per hour prescribed dose, so that we can have a delivered dose of 20 to 25. But since introducing citrate into our unit, we have very little circuit interruptions, very little downtime. And so our patients over time have accumulated very excessive doses, just as a result of not having that downtime that we account for in the prescription. We also, how our citrate, which is our standard of care anticoagulation, how we prescribe it is that it's given in the pre-blood pump fluid. And so that's then linked to the blood flow rate. And as part of our current protocol, we match that to the dialysate. So most patients are receiving total exchange volumes of about 3,000 mils per hour, which for many patients is excessively high. And perhaps for some obese patients is underdosing. And so we're currently auditing our own behaviour. And like the CRRT net registry results, we're finding that actually it's a smaller proportion of patients than we thought actually receiving doses of CRRT within the recommendations from the KDIGO guidelines. And so we have modifying our protocol at the moment to allow more flexibility with blood flow rate and therefore pre-blood pump fluid to try and limit the total dose being excessively high or low. So having a more personalized approach. The impact of, so I know not all units use dilute citrate in pre-blood pump fluid, so a lot of other prescriptions allow much more flexibility, but we're sort of trying to troubleshoot within our prescription. But I do think that it's really important for units to look internally and see what's actually being delivered in your unit as a quality measure, because I was certainly really shocked to see our results, and then to think about the impact of these results on things like drug clearance, requirement for electrolyte replacement, all the dialysis fluids and electrolytes have environmental and sustainability impacts, which we'll hear about in the third webinar. So I think it's really important to do internal audits to assess your own activity.
Yeah, I think it's a very nice description of our attitude. We do want to do it well, and then sometimes we overdo it. And the other thing is that we're starting at high doses, but never adjusted, despite all the like BUN or creatinine is going down massively. So I think this will be probably the part of the next webinar, and by that I might guide the interest of our listeners to the following webinar on dynamic dosing in April 28th. So, and then we'll have another one on May 26th on sustainability, as Emily already indicated. Now, thanks, Emily. It was really great to listen to your wonderful talk. I want to thank Nordia explicitly for supporting this initiative, which I think is a very important aspect. And finally, last but not least, I would also like to give a bit of advertisement to our International Society of Critical Care Nephrology. You're welcome to join us. We are joining EC by the website. So with that, I think we can conclude. Thanks again, Emily. It was fantastic. Thanks to Kieran for supporting this, for Nordia for supporting this. And I wish you all a nice evening, day, morning, whatever time zone you are. Thanks. Goodbye.